Chapter 29, The High-Risk Newborn. Late preterm infants are ones born between 34 and 0.7 weeks and 36 and 6/7 weeks gestation. Many times late-term infants are not recognized as premature because they look full-term. They're at risk for respiratory distress, poor thermoregulation, hypoglycemia, hyperbilirubinemia, feeding difficulties, acidosis, and sepsis because of the immaturity of their body systems. Thermoregulation is something our late preterm infants can have issues with. Typically checking their temps every 4 hours is recommended. Having the parents do skin-to-skin or kangaroo care is a good way to help these infants warm up. If this is not effective to maintain the temp, they may need to be placed back under the radiant warmer to increase their temp. Feeding issues is also another concern. They may have an immature suck reflex, and this can make feeding difficult. They do have an increased calorie need and should be fed every 2 to 3 hours. We need to assess their feeding ability with monitoring sucking and swallowing. Accurate I's and O's is needed as well. They're also at risk for hypoglycemia due to their immature system, lower birth weight, and feeding difficulties, so following protocol for glucose checks are needed. Assessing for signs of hypoglycemia, which include poor temp control, jitterness, high-pitched cry, also needs to be done. These infants should not be discharged before 48 hours old. They need to be feeding well, maintaining their temp, bilirubin levels within normal range for their gestation age. Education needs to be provided to parents regarding complications that can occur and signs to watch for. How to keep the infant warm and accurately take a temp, have a proper car seat that fits the infant, and watch for signs of overstimulation. The exact cause of preterm birth is not known. Prevention is a key, and the main component that seems to make a difference is adequate prenatal care. During prenatal care, we teach about signs and symptoms to report to the provider so early detection can be made. The characteristics of a preterm infant varies upon the gestational age. Some of the things are the same in all gestations if they tend to look frail, weak, and less muscle tone than a full-term infant. Their head appears to be large for their body. Their skin appears red and transparent from the lack of that subcutaneous fat. Lanugo and vernix can be abundant. The pinna of the ear has little cartilage. Respiratory problems are a major issue for preterm infants. This is due to the lack of surfactant in the lungs to keep the lungs inflated. The nurse must monitor for episodes of apnea. Periodic breathing is the cessation of breathing for 5 to 10 seconds without other changes and can be followed by rapid respirations. This is a normal finding. Apneic spells are periods of no breathing for more than 20 seconds or accompanied by cyanosis, pallor, bradycardia, or hypotonia, and is common in the preterm infant. They will also watch for signs of respiratory distress, which include retractions, nasal flaring, and grunting. Grunting can be an early sign of respiratory distress syndrome. Nursing interventions include working with respiratory therapy to manage respiratory status. Oxygen may be given via nasal cannula and an oxyhood. There's a picture of that on page 621, or they may be on CPAP. The oxygen needs to be warmed and humidified. Pulse ox monitoring will be necessary as well. Side-lying and prone positions work well to help drain the secretions. Infants need to be suctioned if excessive secretions, so be sure the equipment is working properly. Also needs to be done. Maintaining adequate hydration will help keep the secretions thin as well. Thermoregulation is another complication that can occur with preterm infants. This is due to having thin skin, less subcutaneous fat, and less brown fat. Once an infant cannot maintain a stable temp, they're at risk for hypoglycemia, metabolic acidosis, vasoconstriction, impaired surfactant production, and hyperbilirubinemia. Temp is monitored continuously by a probe on the infant's abdomen, which is attached to the heat control mechanism on the warmer or the incubator. Signs of inadequate temp control include poor feeding, irritability followed by lethargy, weak cry or suck, decreased muscle tone, hypoglycemia, respiratory distress. Interventions include being aware of the 4 ways the infant can lose heat and avoiding these. Being aware of their air around them, not putting cold items on the skin. Weaning from the incubator or warmer to the crib should be done gradual. Follow protocol for agency, but should be done slowly with frequent monitoring of the ability to maintain the temp within normal limits for gestational age. Preterm infants can lose fluid very easily. They have a large surface area compared to their body, so they can lose fluid rapidly. Immature kidneys have a hard time balancing fluid and electrolytes, which can cause many problems. They will monitor I's and O's and daily weight to determine fluid status. Watching for signs of dehydration or overhydration is needed as well. See the safety alert box for the differences. If you have IV fluids running, careful assessment of the IV at least every hour. Preterm infants has skin that is thin and very fragile, so all the things that are on the skin, IVs, electrodes, etc., can be very damaging to the skin. We must continuously monitor the skin for any breakdown or tears and make note of any of these changes. Note which products causes issues and document them so they're not used again. A few things we can do to limit damage to the skin is to use cotton between the tape and waiting at least 24 hours before removing it. There are barriers that can be used to help prevent the breakdown of skin as well, and hydrogel or a hydrocolloid dressing should be used when the skin is breaking down. They will help promote the healing. All disinfectants can harm the skin, so checking with the family for which ones they use. Alcohol should never be used on a premature infant's skin. Frequent position changes also needs to be done to prevent skin breakdown. Preterm infants are high risk for infection and sepsis. Most will have one or more episodes of sepsis while hospitalized. This is due to the exposure to maternal infection, lack of transfer of immunoglobulin G from the mother during that third trimester, and an immature immune system. Hand hygiene is the #1 way to prevent infection. Healthcare workers must wash their hands frequently. Also, being sure any visitors are healthy will also decrease the chance of infection. Good assessment skills are needed so early signs are made aware of so the provider can have treatment measures to be started. Many preterm infants go through painful procedures while hospitalized. Pain can increase the ICP, which can cause hypoxia, changes in metabolic rate, and they can have adverse effects of growth and development. The nurse must assess for pain. They can use a premature infant pain profile known as PIP. It looks at gestational age, heart rate, pulse ox, brow bulge, and other areas. Nursing interventions include containment of the infant, non-nutritive sucking, sucrose on the pacifier, 2 to 3 minutes before a procedure can help as well. Medications may be ordered as well, and the nurse may give as prescribed. Environmental issues causes stress, things like noise, bright lights, and too much stimulation. We must assess these areas by being aware of the noise level. It is more common in areas where people gather, which include doorways, sinks, and the areas of computer access. Being aware of these things and limiting the amount of noise can really help a preterm infant relax. Too much noise, bright lights, or overstimulation can cause a change in oxygen levels and behaviors. The measures we can do as nurses is to schedule care. We have to allow time for rest between the necessary care. Also, short rest periods during longer procedures can help as well. Reducing the extra stimuli by keeping the noise down, being careful that incubators are not placed close to those noisy areas, keep bright lights off from the infant. You can drape blankets over the incubators to reduce the lights. Individualized care for each infant is necessary as well. What one infant may tolerate, another may not be able to. Careful assessment and paying attention to detail is needed. Other signs of overstimulation include changes in vital signs, cyanosis, pallor, mottling, nasal flaring, sneezing, and coughing. Behavioral changes include stiff extended arms and legs, arching, turning away from eye contact, yawning, and fatigue. Nutritional needs of the preterm infant is always a concern. Many times they are born when their digestive tract is still immature. Hypoglycemia is a common concern. Preterm infants receiving enteral feedings should receive 105 to 130 kcals per kilogram per day. We must assess how they tolerate feedings, whether they are by gavage feedings or nippling. If gavage feedings, aspiration of stomach contents is necessary and following the protocol is crucial. Abnormal amounts are to be reported to the provider per protocol as well. Watching for vomiting can also tell how they are tolerating feedings. During gavage feedings, we must watch for signs that the infant is ready for nipple feeding. This includes the rooting reflex, active sucking, respiratory rate not above 60 breaths per minute, and they have a gag reflex. Being a parent of a preterm infant can be a very stressful time. They typically were not prepared for this and have not had time to adjust. Depending on the gestational age, the infant may not look anything like what the parents had expected, and that can be very upsetting to parents. An added stressor can happen if the infant had to be shipped to a different facility, especially if it is in another town. Transportation and care of other children can be great concerns. Sometimes they may have a delay in that bonding process. They may be afraid to hold or not allowed to hold. We encourage touch as allowed. Preparing the parents for what they will see will help. Talking to them about all the tubes, lines, alarms, and other noises before they see their infant can help. Encourage the holding or touching as well. Keeping the parents updated and providing support is a big part of the nurse's role. Not being judgmental if the parents cannot stay the whole time with the infant. If they have other children at home, they may not be able to stay all the time. Being understanding can be helpful. Once allowed, we want to initiate kangaroo or skin-to-skin care. This can be done by mom and or dad. Explaining the normal behaviors and teaching them how to look for overstimulation can help as well. We encourage them to participate in care and decision making. We'll start helping them prepare for discharge. Many times these infants may go home with special equipment, including apnea monitors, so education and training needs to begin early as possible. Educating on signs to report back to the provider as well will need to be done. We must explain that for premature infants, they may not hit the major milestones like rolling over, sitting up, etc. at the same time a term infant reaches these milestones.